Good afternoon, everyone, and welcome to our March Telehealth Learning Collaborative hosted by the North Country Telehealth Partnership, joint effort between Adirondack Health Institute and Fort Drum Regional Health Planning Organization. My name is Nancy Del Mastro. I'm the Telehealth Project Manager at AHI, and thank you for joining us this afternoon. We're really excited to get started with our presentation by Fort Drum Regional Health Planning Organization's Robert Hunt, who's the Fiber Network Manager. And we're actually going to start with his presentation. I know the past few meetings we've started with our state and federal policy updates, but we will not be hearing from those partners. I'll be sharing a few links after the presentation when we provide some updates. So at this time, I'm going to pass it over to Robert Hunt to start the presentation. Thank you.
Thank you, Nancy. So we're going to give you a quick overview of the fiber networks that are in upstate New York. Most of you are aware there are two large fiber networks, the North Country Telemedicine Project, administered by the Fort Drum Regional Health Planning Organization, and the Adirondack Champlain Telemedicine Information Network, or ACTION, also administered by FDR-HBO, but starting a little bit later in the cycle. And we'll just get into where we started in 2010, when most of the healthcare facilities in this country, and certainly in this part of the United States, were running 56 kilobit and T1 lines as their primary pipe to the public internet. So there are multiple programs that are responsible for the two fiber networks that we have in place. The first one is the FCC's Rural Healthcare Pilot Program. The second one is the FCC's Healthcare Connect Fund, which is the replacement of the original pilot program. And then, of course, New York State's Rural Health Network Development Program. So the first step in upgrading last mile facilities to many of our very remote healthcare partners was utilizing the FCC's Rural Healthcare Pilot Program, of which FDR-HBO was an early adopter. That program allowed us to not only build out fiber to places that at that point, as I said, we're getting 56 kilobit, maybe T1, which is a 1.544 megabit circuit. Many of them were getting satellite services because there was no infrastructure to connect them. This program not only allowed us to put out an RFP for bid for last mile services, but it also allowed the users to only be on the hook for 15% of the total cost of those build outs. And those build outs in some cases were very expensive. Average build outs of 30 to 40K were not unheard of. Some build outs as high as 300 to 400K, depending on the rurality of the location. And then we build upon that with the Healthcare Connect Fund. And then on top of that, of course, there's no point in having fiber networks for telemedicine if we're not going to develop telemedicine programs, which is what the Rural Health Network Development Program allowed us to do. So in 2005, the DoD created a pilot program basically to identify and analyze the existing healthcare delivery options in the Fort Drum Health Service area. And the reason for that is Fort Drum is the only Army installation that has a full division that doesn't have its own hospital. There's, a couple of smaller installations that don't have a hospital, but Fort Drum's the only one that with a division that doesn't have its own on-base hospital. So the idea was to leverage the existing healthcare resources in the region to administer services both to the active military personnel and to their dependents. And Fort Drum and Yuma, Arizona, were selected for that pilot program. It was through this initiative the money was set aside in a congressional budget to fund the creation of Fort Drum Regional Health Planning Organization. And one of the first things that FDR-HPO did was to apply for the FCC's Rural Healthcare Pilot Program in 2007. Now, at the time, uh, the Action Network was being managed by another entity and not FDR-HPO. That changed in late 2009, early 2010, where FDR-HPO took over that program. Both Action and NCTP were awarded an initial amount of money to be spent over a 3-year period to build out new facilities and to tie all of those facilities together into networks where each user was able to talk to the other user, essentially private networks from the perspective of the service providers that helped us to establish these networks. That program, the Rural Healthcare Pilot Program, ran through 2013. And once the pilot was finished, the FCC was pleased with the way the pilot went and decided to continue it under a new program called the Healthcare Connect Fund, which started in 2013. So NCTP, which is, and I'll show you where all the sites are as we get further into the presentation, but we submitted the application in 2007. It was approved that same year, and we were awarded almost $2 million. So under the Rural Healthcare Pilot Program, the user pays 15% of the total cost for one-time installation services and monthly recurring charges over a 3-year period. And then USAC is the Universal Services Administrative Corporation. They manage the FCC programs under the Healthcare Connect Fund, the Rural Healthcare Pilot Program, the Libraries Program, the Telehealth Program, all managed by USAC. So USAC approved our request for funding, and the initial build out started in April of 2010. We started out with 28 locations, and we ended up with 46 locations as of March of this year. The total funding that we've received, because again, this program ended in 2013, so we've continued through 2023 under the Healthcare Connect Fund. We've $5.8 million, of which the users have paid $1.5 million. So between the two programs, there's been a significant cost savings, obviously, to build out the initial networks as well as the ongoing networks. For the Action program, they also submitted a request in 2007. Their program was going to be a little bit different than the FDR-HPO program. They were going to try and create a private service provider. And through that service provider, they were going to offer services to the local communities, and the sales of services was going to support the funding of the healthcare entities at no cost. Unfortunately, that program fell through, and FDR-HPO stepped in to change the scope of the program in December of 2010 to just create a private network, initially standalone, where the Action users would again be connected over a layer 2 fiber Ethernet service and have access to the public internet. Again, USAC paid 85% of those costs, and the costs of the build out for Action were significantly more expensive, and the users paid 15%. The original plan for Action had 4 main hospitals and 10 or 12 clinics that are affiliated with those hospitals. That was expanded significantly to ensure that we got the biggest bang for the buck. So the initial build out was 50 sites. We've had some sites go away, not that they're off the network, but that they were replaced by dark fiber services. But we're down to 37 sites for the Action network. They have received a total of $12.3 million in funding since the start of the program in 2010, and their users have paid $2.5 million. because the bulk of the funding that was received, the initial $7 million award, 85% of that funding was paid by USAC, and a great percentage of the money that was spent was for infrastructure build out. So they got the best bang for the buck with regard to building out infrastructure to very rural locations that simply didn't have anything in the way of fiber connectivity prior to these two programs. So the Healthcare Connect Fund replaced the Rural Healthcare Pilot Program in 2013, and the fund originally uh, was capped at $400 million per year, and that was not a problem in the initial years of 2009 through 2016. But around 2016, 2017, the requests for funding outstripped the amount of money that was available. And we got into a period of time where we weren't getting the full 65% funding from USAC. For approved funding, it was a percentage of 65% of the funding. Naturally, this caused quite a bit of consternation. So lots of letter writing and appeals to the FCC took place, and the FCC came out and increased the funding cap to $571 million in 2017. And then in 2018, they adjusted the funding cap to reflect inflation, and they provided a process to carry forward unused funds from past years to be used in future years. So since that time, we haven't had a funding year where more funds were requested than were available. The reason this is an issue, FDR HPO, like many large networks, requests multiple years of funding at one time. Some programs, if you requested 2 or 3 years of funding every year, the funding that was required for the second year would come out in the second year's budget, and the funding for the third year would come out in the third year's budget. USAC doesn't do that. They take all 3 years of funding out in the year in which you applied. So that can have a fairly large impact on the amount of money that is available. And it is one of the reasons that we started changing how we request funding from that time forward. So NCTP migrated from the Rural Healthcare Pilot Program to the Healthcare Connect Fund in April of 2014. Action migrated in December of 2015. The Healthcare Connect Fund only pays 65% of installation and monthly recurring costs, and the user is now having to pay 35% of the costs before they can be reimbursed for the other 65%. So what are the services that are offered on the two networks? There's intranet services. Those are layer 2 fiber Ethernet services where any user on the network can connect to any other user, either at layer 2 or a layer 3 VPN service, without going over the public internet. So that gives us an additional level of security in that the two networks, Action and NCTP, are not publicized to other service providers out in the World Wide Web or the public internet. So they are, for all intents and purposes, seen as private fiber networks. The other service that's available is a shared 2 gigabit public internet service. So essentially, we set up a hub and spoke, and you'll see that as we go forward. Locations like hospitals that have multiple affiliated clinics, the clinics, when they need to access the public internet, they actually come back to the hospital, and then the hospital routes them out to the public internet, so that that shared public internet service for either network is only utilized by the hospitals or any standalone entities like a public health facility. That's important that we have the 2 gig shared. And we also, going forward in 2016, we merged the two networks logically over a common backbone, which is provided by the Development Authority of the North Country. So essentially, if the shared public internet service in the Action Network were to go down, and it is geographically redundant, and it has two different points of access, and all of the equipment is redundant. But if both of those sites, for whatever reason, should all of a sudden just disappear, all of the traffic in the Action Network would be routed over that shared backbone, and those users would then share the public internet service that is on the NCTP network, so, and vice versa. And then, of course, if when the services are restored, then the traffic reverts back to its primary public internet service. We also have a managed firewall service for those smaller locations that don't want to manage all the ins and outs of a firewall, especially with all of the issues that we have regarding denial of service issues. Managed firewall service by the provider is one of those handy things to have. And then finally, to track all of these services, we have a mission critical app, which is offered by Westelcom. We use the app to open trouble tickets. With the app, you can see the ticket opened, you can follow the activity of the service provider, seeing what they're doing to restore the service. You can add your own comments for any troubleshooting that you've done yourself that may be of interest to the service providers as they're going about trying to restore the service. Maintenance notifications are included in the app. And then each location can get a traffic analysis by autonomous system number or border gateway protocol or domain name server or the top destination or a statistical representation of the amount of bandwidth that they're using at their location going in and out, both to the private intranet and to the public internet. So when we started this, as I told you way back when, we had some very low bandwidth sites that were being utilized. And, you know, I've got some file types here to give you an idea of both the types of files that are transferred on a daily basis, and then their, you know, typical average size. So a web page that you're viewing with static data is a 1 megabit file size. A chest X-ray, 20 meg. A CT scan of the heart is a gig. A 4K movie, if you're watching that at home, not certainly over your telemedicine network, is 28 gigabits. If you try to send any of these files or receive them over a 56 kilobit service, I think you can see for that 4K or HD movie, you'd be waiting quite a few days before you could view any of that information. A chest X-ray for somebody in the emergency room, close to an hour, an ultrasound, over an hour and a half, an MRI, 9 hours, and a CT scan, you were going to be there waiting for that quite a bit. Those were the worst case scenarios. Some of the hospitals had a little bit better connection. It was called a T1, which is 1.5 megabits. So your times improve, but again, you're still waiting an hour and a half for a CT scan. You're still waiting half an hour for that MRI of the heart. And, you know, if it's busy, time is a critical element, and it certainly was detrimental to some people to have to wait these amounts of times for an image, not just to be sent, but for somebody to view it and make diagnostic annotations about it and then send it back. These are just one way. So, you know, for again, the MRI of the heart, 22 minutes one way. Somebody's got to review the image and then send it back for another 22 minutes. So time is critical. The first thing we did in the first iteration was put a minimum of a 10 megabit circuit for every location. And as you can see, now our times have dramatically improved. Worst case scenario, that 4K movie, that went from 46 days to at 56K, 1 day at a meg and a half, and now we're down to 6 hours. Our next improvement was at 100 megs, and now we've got everybody in the 60-minute window. 4K movie, 37 minutes, worst case scenario. That chest X-ray, 1.6 seconds each way. Ultrasound, 3 seconds each way. And then finally, we've upgraded many of the larger sites to a full gigabit, which is 1,000 megabits. And now everybody is under 5 minutes. Worst case scenario for any type of data that we're trying to send at 28 gigabits and below. So that's a fantastic improvement in the efficiency of both the clinics and the hospitals for sending and receiving information for their patients. So how do we go about achieving these services? Well, FDR HPO, as I said in the beginning, is the administrator for both of these networks. We've had to file RFPs. Those are requests for proposals. We did 3 under the Rural Healthcare Pilot Program, 4 under the Healthcare Connect Fund. That's for each network. So 6 under the Rural Healthcare Pilot and 8 under the Healthcare Connect Fund. As you can see, it takes quite a bit of time. There are forms that are required as part of any federal process. So the first form, and we can forget the Rural Healthcare Pilot Program, going down to the second set of bullets, the Form 460, so that identifies you as either an eligible or ineligible participant able to receive funding. The Form 461, that's the RFP. The Form 462, that's the request to get the funding after you manage to find a service provider to provide you the services and they've told you how much it's going to cost. And then assuming that Form 462 is approved, then monthly or quarterly, annually, we file a Form 463 to go and get that 65% payment for services that have been rendered. So this is what the network looks like today. NCTP has 11 hospitals, 23 clinics, 2 public health, 1 specialty clinic, 8 community health clinics, 1 admin site, that's FDR HPO. Action is all hospitals and clinics and a single data center. I'll send a link at the end of this program where you can click on each one of those yellow and purple sites, and it will actually tell you the name of the site, the bandwidth, and where they're located. But as you can see, the red is the fiber links that connect all of these locations, and it's an extensive build out. Most, probably 95% of those fiber links in the middle and along the top didn't exist prior to us starting the Rural Healthcare Pilot Program back in 2010. So this is a busy slide, but essentially it's a logical depiction of what you just saw on the slide before. If you look at the very top where it shows Messina Central, you can see on the left-hand side there, it's got a couple of clinics that are connected to it. It in turn resides on fiber networks that connect both Ogdensburg and Potsdam Central, so on and so forth. I'm not going to force you to read through all of this, but these are essentially fiber rings. They're self-healing. In the event one side of a connection goes down, the other side, it loops at both ends, and the data just routes around in a different direction. NCTP was that one. This one's Action. They did this one a little bit differently. These were drawn up by the service provider. So now they're actually showing you the clinics that are connected to each one of these affiliate links, the hospitals themselves. Some of the nodes are just routers or layer 2 switches. That's the Action connectivity. And this is the bigger overview. Essentially, we have 2 large rings that connect both Action and NCTP. We call Action and NCTP consortiums because that's a term that only is applicable to USAC, but essentially all of their funding for all of the sites that are in both networks is dependent upon them being part of a consortium on paper. So all of those yellow dots that you saw a couple of slides back, those are the action ones, and the NCTP ones were the purple. And in the event there's any type of a break, traffic routes around in another direction. You can see there's two geographically separate internet uplinks. So in the event one link goes down, all traffic routes to the other link and vice versa. So service providers. So the initial RFP that was put out for NCTP attracted a single vendor response for the solution. We put out the second one, we got multiple vendors, but they were all single vendor. What that means is, for example, AT&T bid on one of the RFPs, and it was all AT&T at every site. And Dank bid on one of them, and it was all Dank at every site. And we felt internally that that limited us in terms of getting the best bang for the buck. We wanted to utilize last mile services that were already built. We spent quite a bit of money in the first iterations doing build outs to places where nobody provided service. But as the networks matured, there were multiple vendors locally that could provide services for the last mile. What we required of winning bidders from 2014 on up is that a single vendor be responsible for the backbone of the network, and that vendor have sub vendors that would be responsible for providing all the last mile resources. So you don't get a single vendor solution anywhere. You have multiple vendors. They all have co-location agreements with one another. So their services end up on the backbone of, in this case, the Development Authority of the North Country. And everybody is on the same backbone. And if there's multiple vendors at a location, through the RFP process, the last mile vendor with the best pricing ultimately gets picked for that location and is and terminates its services onto the existing Development Authority backbone. So today we have Dank providing the backbone and quite a few last mile locations in the NCTP network. Westelcom provides locations in last mile locations in both the NCTP and the Action networks, as well as the internet services for both networks. We have Metronet for some of our users on the NCTP network that are in the Syracuse region. We have Crown Point Telephone for some of our Action users, and we have Slick network solutions being utilized for both Action and NCTP users. And we have First Light for quite a few, again, of our Action users. So we have all of those service providers that are providing these services for both networks. So going forward, current funding for both networks runs through June 30th of 2025. So we'll be doing new RFPs for NCTP and Action for new services in July of 2025. Letters of agency, those are forms required by the FCC and USAC that say that members that are participating in a consortium and have an administrator administering those consortium entities must give permission to the administrator to file an RFP and go into a contract for services on their behalf. Everybody in both networks has a letter of agency on file. Those are all due to expire in June of 2025. So we anticipate filing the new RFP sometime between July of 2025 and it says April, but that's the filing window. That's when it would close. So the filing would actually have to occur sometime in January or February, which is what the next bullet says. And then we'll file the Form 462, which is the request for funding. Whenever the filing window opens for that, they haven't told us yet, so we don't know. We'll still get funding for 10, 100, 1 gig. We're going to introduce a new 10 gig service. We already have that for some networks. services on the current NCTP network. And we're going to look at peering arrangements between companies like Microsoft and Azure, Microsoft Azure services, as well as Amazon AWS services. Peering arrangements simply guarantee what the quality of service is going to be from point A to point B. You cut out all of those bad internet paths and have more of a direct point-to-point connection between you and the entity that's providing services like Microsoft Office 365, for example. So that will be available as well. The Rural Health Network Development Program funded by New York State Department of Health. We currently are tracking 154 projects, telehealth applications. These are just a few of the ones that we've tracked over the years. There are obviously many more, but these are the big ones. We have, since we started counting in 2014, tracked over 470,000 telehealth encounters. And as you can see, in 2014, we had a single telehealth encounter that we were able to verify. It ramped up slowly to where we were averaging about 3,500 a year. And then something happened in 2020. I'm sure most of you can take a guess as to what that was. COVID dramatically increased telehealth applications and telehealth services. We've seen a tapering off, obviously, as restrictions on face-to-face encounters have changed as the pandemic itself has changed. But we're still seeing significantly more annual telehealth encounters than we did prior to 2020, and we expect that that will continue for the foreseeable future. So what are some of the services running over the telemedicine networks from the hospitals and clinics themselves? A plethora of things. The biggest is the remote access to EHR and EMR services. A lot of patient portal access. There's things you wouldn't think about, which is the voice over IP and video teleconferencing services. A lot of the hospitals in 2009, 2010, 12, those were standard POTS type services, copper telephone services back to the hospitals. Those have all been replaced by voice over IP services, which has resulted in a significant savings to their annual budgets. Appointment scheduling, community health reporting, IT support, obviously, both locally and across the network. Because again, anybody on the network is able to talk to anybody else on the network at layer 2. And we just have so many services that we're able to utilize now because we're all interconnected. And that's basically everything in a nutshell. I've provided my contact information. There's links to the history of FDR HPO and our telemedicine information, and more information about the telecom services that DANC is providing as the lead entity for both Action and NCTP. And if there are any questions, I'll take them now.
Thank you so much, Bob. That was really helpful, I think, for a lot of our partners that may not be familiar sort of with the technical side of what is supporting our telemedicine efforts throughout the region. We do have a question in the chat that I'll go ahead and read to you. Is there anywhere healthcare organizations can go to reach out to advocate for improved cell tower availability? Specifically in the Adirondacks, fiber networks are great, but my agency has about 200 employees using cell towers for daily field work. DOH has strict regulations on utilizing technologies, but the lack of infrastructure makes full compliance quite difficult.
I agree. So obviously, the local service providers that I showed in the slide that lists what local providers are providing services also provide services to cell towers. So I would start with the Development Authority of the North Country. I wouldn't just limit myself to cell towers, because as we're getting into low Earth orbit satellite services and cell phones that are starting to come out in the next year that will be able to access those satellite services, they actually have a response time very similar to the cell services, 30 to 50 milliseconds, some even lower. So I, I would start with the service providers, obviously, the ones that are here local, uh, because they are not just in the business of providing fiber to those cell towers. They are actually part of the group of carriers that are building cell tower services. And again, I would also look, if you haven't already, about low Earth orbit services that will certainly cover all of the locations that we're talking about in upstate New York. I know they've been rolled out in this area from Starlink, for example, in the last year. So those are two things I would look at.
Thank you, Bob. I don't see any other questions in the chat right now, but I'll give everyone another couple of minutes to put anything in while we have Bob before he has to jump for his next presentation. But thank you again, Bob, for the presentation. Jill from Westelcom just commented in the chat, great job, Bob. I echo that. And again, for our participants, attendees, if there are any other questions for Bob on the presentation, feel free to pop them into the chat or the Q&A box. As a reminder, this is recorded, so we'll get out the recording as well as the slide deck later this week with the notes for your review and reference. While we wait for some or any other questions that may come through from attendees, we'll go ahead and just talk through some of the other updates that were shared in the agenda when we shared that earlier this month. We wanted to get everyone aware of the upcoming New York State Empire State Development's Connect All listening tour that they're hosting throughout the state. The Connect All office, as other people may have known, it used to be the broadband office for New York State. They are now going through New York to learn more about digital equity and broadband needs. And this is being supported by some federal funds. They're the broadband deployment and digital equity planning funds that the NTIA has deployed to states. And essentially, the Connect All office is looking to hear about the barriers to digital equity. Is it broadband access, devices, digital literacy, and so on and so forth? What resources and assets we do have throughout the regions, and what New York State really has to focus on as they work to create a digital equity plan and support, additional broadband coverage throughout the state. That being said, the Connect All's visit to the North Country will be taking place on March 28th, so next Tuesday, from 1 to 3 p.m. This is going to be a hybrid style meeting. We will be in person in Tupper Lake at the Wild Center for those who can join. And for those who can't make the trip but are looking to be involved in the discussion, there will be a Zoom link, and I'll make sure to put the registration link in the chat. We'll be hearing actually from Dave Wolf from DANK and Beth Gillies, who will be talking about broadband infrastructure in the region, plans, and partnerships to address gaps. We'll also be hearing from Steve Hunt on the region's economic and workforce development goals to assist with digital workforce in the economy. And I'll be discussing the North Country Digital Inclusion Coalition and talking about some of the awesome work that our partners are doing throughout the North Country to address digital inclusion needs. After a couple of presentations, we'll be moving into some breakout sessions where the state is really looking to hear from community members and community organizations that are working directly with our communities on addressing these needs and really talking through some of the barriers. Um, and that will be a really awesome meeting that we're really excited to host. So again, I'll be placing the registration link in the chat, and I'll make sure that some further information is put into the notes document as well. If you have any questions about that, feel free to reach out to me. And I do see that I do see actually another question for you, Bob.
Okay.
It says, will RHC funding cover Starlink fees, or are there other ways to help offset those costs?
So it's kind of it's a maybe question. RHC, the Rural Healthcare Program, does not allow you, when you put out a bid for services, to specify the format in which those services are offered. It has to be whatever is the most cost-effective format that meets the criteria that you put in the RFP in terms of these are the minimum things that the service, whatever that service is, must be able to support. So for example, on our fiber networks, I can't ask for fiber from one point to the other, but I have to define the service in such a way that the only thing that could realistically meet my needs is a fiber type of connection. So in your instance, if you would shoot me an email with that question, I will send it to USAC and ask them for their input as to whether or not anyone has requested those services. And if not, what their feeling is in terms of whether or not they would approve it.
Thanks, Bob. Don't see anything else in the chat. I know you do have to run soon to get ready for your next presentation. But if there are any other follow-up questions, like Bob mentioned, his email is on the slide, and we'll be sure that that is also included with the notes as well if you have any follow-up. Just a couple more updates before I let y'all go. It looks like we'll get everyone out a bit early, which is always, I think, appreciated to have a bit more time in your day. In addition to the Connect All visit, just to talk through what's happening on the policy side of things, I think everyone should be aware that the federal public health emergency will be ending in May. Tony and the team at CMS has shared quite a few times now about the Consolidated Appropriations Act, the waivers that are extending telehealth waivers and flexibilities through 2024. The notes document will have all of those reference links to CMS guidance documents if you haven't seen those. And if you have any questions, of course, feel free to reach out. In addition to our federal public health emergency updates, I just wanted to share on behalf of DOH a new comprehensive guidance document regarding the use of telehealth, including telephonic services after the public health emergency. And I'm going to put that link in the chat. Again, it will be included with the notes as well. That's going in right now. So again, that's the special Medicaid update that went out last month from DOH. And then OMH also did create a new policy guidance document as well, just to discuss the impact of the end of the public health emergency on OMH systems. So I'm going to place that link in the chat as well for your reference. Again, those will all be in our notes documents. But other than that, there weren't any new updates from our state and federal partners to share during the meeting. The notes documents will have some great overview, FAQs, and guidance documents from the Center for Connected Health Policy. CMS also recently created a few provider-specific fact sheets regarding the PHE waivers and flexibilities. So these are all just helpful guidance documents to keep on hand as we approach May 11th, when the public health emergency is set to end. And of course, we'll keep y'all updated if there are any other changes or news that we hear on our end regarding the COVID-19 emergency and waivers, flexibilities, and so on regarding telemedicine. I don't see any other questions in the chat for you, Bob. So I think we can go ahead and end a bit early today. Our notes document will have a few upcoming webinars and other opportunities that you can look into and register for. We have a save the date out for the Northeast Telehealth Resource Center annual conference, and keep an eye out for our North Country Telehealth Conference save the date in the next couple of months as well. We're excited to be back in person this year. So in the next couple of months, you'll see some information regarding the planning efforts along for that. So if there's anything else, feel free to reach out to myself, Bob, any of our partners at AHI or Fort Drum, and we'll be really happy to assist you. And we look forward to seeing you at our next Telehealth Learning Collaborative, which will be held on May 15th from 2 to 3 p.m. Thanks again, Bob, and for everybody for joining us, and we'll see you in May.
Thank you.